Hello, welcome to this Sustainable Care Programme conference session. This is part of Theme 4, and in Theme 4 we're looking at care markets, how and for whom do they work? And the focus of today's session is on equity and inclusion as part of care markets. Delighted to be joined today by two fantastic presentations and bodies of work. So today we'll be hearing from Mo Ray from the University of Lincoln and Gabrielle Meagher from Macquarie University. So we've got a paper that looks mainly at England and a paper that looks mainly at Australia, but lots of really interesting resonances and connections between them. And our discussant, Emily Byrne from the University of Birmingham, will be helping to draw those out and bring us into the discussion later on in the session. Each of the presenters and discussion will present for around 15 minutes, and then we will come together for a discussion at the very end. So I'll get straight on to the presentations. We're going to start with Mo Ray. Mo from the University of Lincoln is going to be focusing on a presentation entitled A Careless System, Navigating the Care Market as an Older Self-Funder. So Mo, thanks very much, and over to you.
Thank you, Catherine, and I'm very pleased to have the opportunity of presenting this research at the Sustainable Care Conference. Just to say, I worked on this project with Lizzie Ward, who's the lead researcher from the University of Brighton, and also Denise, who is lead researcher for Solihull, based at the University of Birmingham. Today I'm going to mostly focus on two themes that emerged from our fieldwork, the issues around choice and also control. But first, I just want to say a few words about self-funders in an English welfare context. And I think I'll start by setting the context by defining what we mean by self-funder. Next slide, please. So this definition by Baxter and Glendinning defines self-funders as someone who pays for all of their social care or support from their own private resources, including social security benefits such as state pension, attendance allowance, or they top up their residential or their domiciliary care funding with additional private spending. And it's important to say that older people are by far and away the largest group of people who pay for all or part of their care. Our case for doing research highlighted a number of critical factors. Next slide, please. So first, despite the very long presence of self-funded care, so as long as social care has been financially means tested, self-funders have existed, and yet I think it's to say that we know very about them. As I say, the oldest people are the largest group of people who self-fund by a considerable margin, but we don't know how they go about organising their care, paying for their care, deciding on need, managing care, what they do when things go wrong. And the second, old terms of their active voice in any discussion about social care or being a self-funder in that context, I would argue are very much at the margins. So as a group of people who pay for their own care, for example, there is no formal representation of them in any social care debates or discussions. I think it's also important that self-funders and their stances, and indeed the critical role that they play in a contemporary context in supporting a very difficult social care market, is both recognised and understood and appropriately included in social care reform, which has been promised for later this year. We know that one of the challenges of population are people reaching advanced old age, so we're likely to see more people, increasingly complex needs, who are self-funders, and so to purchase ever more complex types of care. As I've already indicated, self-funders have a very significant impact on the social care market. So we can see, for example, how the presence of larger numbers of self-funders in areas of wealth may have greater provision because domiciliary care providers may decide to base their business there and business model on self-funders, and we see that increasingly in various areas, as indeed may care homes. And this can impact on the availability of care for publicly funded service users. Conversely, in areas of deprivation, for example, self-funders are likely to be fewer, and also therefore influence the range of care provision attracted to an area. And of course, there's also the issue of crowding, where an older person in a care home pays more than as a self-funder than a person funded by publicly funded care. We see growing evidence of unmet need, and that's exacerbated by our years of austerity and cuts to public services, and includes self-funding. And it's important from the perspective of integrators that people across the system understanding of funders. So just want to spend a very brief moment explaining how the project was organised. Next slide, please. As I say, the research was set up in 3 sites, each site academic team, and then each site was supported by a community partner who were specialists in providing community services, social care provision for older people. And then each site had a group of older co-researchers who were either directly experienced self-funding themselves, or because they'd care for a family member, or they were interested in social care and social care experiences and social care reform. In Lincolnshire, we had 10 co-researchers who stayed with us for the whole period of the research. And then we had involvement over the course of the project with knowledge exchange attendees who were key stakeholders in social care, and in dialogue with co-researchers and communities and academic teams, we deliberated on and debated emerging findings. We interviewed older people 3 times over an 18-month period, as also unpaid carers were involved in interviews, and we also interviewed stakeholders from the statutory, voluntary and independent sector. Next slide, please. The co-research teams were involved in all aspects of the research, away from developing the research idea in the first place, which predominantly focused on a group based in Brighton, right the way through to developing communication and pathways to impact. I won't spend any more time on that right now, but if you want any more information about the whole co-research, co-production aspect of the research, please do contact me or let me know, or perhaps frame a question. Next slide, please. So we can see that in this diagram, people have to meet 2 sets of criteria for state-funded support. The first is eligibility for care and support, which is defined by national eligibility criteria, and the second is a financial threshold, where they have to be below a certain financial threshold to be eligible for publicly funded care. So just to give you some examples, in the top left quadrant, someone has financial assets and they don't meet eligibility criteria for care, and so they're self-funders. On the top right quadrant, they have high levels of need, so they would meet the criteria for care and support, but they have financial assets in excess of the agreed level, and so they become self-funders. In the bottom left quadrant, the person has low financial assets and their care and support needs are not met, despite the fact that they may have significant care needs, and they become self-funders, or they manage in some other way. And finally, the bottom right quadrant, someone meets the eligibility criteria for care and the financial threshold, and they should then be eligible for publicly funded care. Now just look at the issue of choice in the context of the self-funded market. Next. So within a consumerist idea around the care market, there's often an assumption that if funder, you're going to have a choice of care services, and because you're paying for care, you're going to have more choice than if, for example, who is receiving publicly funded care, who were rely on commission services that were available. What we found in reality. Next slide, please. When we did our analysis, we thought about what's actually implied. So the first condition is that in order to make a meaningful choice, you need to have knowledge about what kind of options are available to you to make that choice. That's consumer behaviour. But our research almost unanimously found that older people and unpaid carers did not know where to start to look for the information and advice that they needed about buying care. It was a complete, I would say it was a complete mystery to almost all all of the people, and they very much felt like they were feeling in the dark without any real guidance or support to tell them what they should be doing. A second condition about choice is that choice depends on there being options from which to choose. But this again was very far from the case, and most often we found that approaches to find care often led to disappointment, waiting times, to calls not being returned, carers not being available for the times that people preferred. And so oftentimes people were reduced to one choice. The care that they could find was the choice that they had. In other words, no choice. The third condition that choice requires is that you need to be making a choice in the right kind of circumstances, such as having time and ability to process information or to weigh up decisions and to look at the pros and cons. But in terms of care, it's not something that can be delayed. The people in our sample needed care quickly or in an emergency. And so oftentimes our research highlighted that people took the option that was available rather than holding out for something that they thought might be better, because they simply didn't have the time to wait. And I just also then want to look at the issue of control. Next slide, please. So control, I think, is closely associated with choice in the context of consumer frame. And the idea that if you're paying for care that you've chosen, you'll also, because you're paying for that care, you'll have control over it in terms of its quality, how it happens, and also what you do if something goes wrong. Next slide, please. So here's what we found. We found that the participants who had the best sorts of control, who felt that they had more control, had care arrangements that they'd established with one or two reliable carers. It was an arrangement that was mutually successful and very much grounded in relationships that had developed and grown over time. But even then, I think it's fair to say that participants felt that they were very concerned about losing a carer or something changing in their own health and circumstances that would result in care altering to the point that they would be left without care. So supposing my carer leaves suddenly, what will I do? And so even when people felt that they had choice, and even when they felt that they had goal, there was that sense of it could change a moment's notice. Often people were paying for and not able to have really a great deal of a say about how things were. So timings, continuity of care were all very much in the hands of agencies who were dependent on what they could provide. So they did their best to meet the needs of individual older people, but they were often very much tied by what they were able to give on staff availability and so on. Of course, the ultimate evidence of control would be exiting the service or exiting the whatever it is you've purchased. But self-funders are not very much different from publicly funded care users in that regard, in that exit is often not an option. Term satisfactory care is a really big decision, given that it could lead to no care, and given that the purchasing care were doing so because they needed it. They needed it to manage their daily lives and to manage their personal care needs. Also, in terms of control, we found that participants faced a very significant responsibility in managing the care that they purchased, and they found it sometimes very difficult to kind of keep a handle on the care that they were purchasing. This involved a number of activities, for example, negotiating with agencies about coping with, communicating with us when things go wrong, sometimes being faced with ending a contract or having a contract end where they were given a month's notice because that particular care arrangement didn't anymore for the care provider, so their care was promptly ended. Negotiating and renegotiating costs, working out how much care needed, and managing the whole issue of finances and bills and invoices. Sometimes participants highlighted impenetrable and difficult to figure out budgeting for change. So there were a number of very complex processes that older people and or family members and or other supporters had to go through to kind of manage and keep a handle on the care that they were purchasing. So we can see that research that despite the often assumed control and assumed choice that self-funders would have in a contemporary care market, we found that this was very the case, and refuted those assumptions, in a significant way. Next slide, please. So, thinking about choice and control and the other research findings that emerged from our research, which we haven't had time to think about today, to identify a number of implications. We think social care policy needs to be founded on a much closer engagement with the lived experience of older people who pay for their care, who, as I said at the beginning of the presentation, are really starkly absent in those sorts of discussions, and in research terms have been until recently. And I think it's important to reveal many assumptions that are made about self-funders and the sorts of myths that prevent a more detailed of the problems that they face. It's no secret in our own context that an urgent review of funding of social care is needed. When that review takes place, it is important circumstances of self included in that, and that they recognise the role that older people who pay for their own care have in subsequent authorities. We also, I think, need to work harder to produce accessible and well-sized avenues for support and to help older people and families who are paying for their own care to be able to access reliable information, to be able to find access to independent advice, and also to think about future planning for people with complex and changing health needs. Next slide, please. So that concludes my brief presentation today, but we have a number of briefings and reports and booklets that the coach has made around looking for care if you're an older person who's going to be a self-funder. That's the project website. That's my email address. So if you'd like to take a look at some of our results, we'd be very glad for you to do that. So thank you very much indeed.
Thanks very much, Mo. That was a really interesting presentation, and it's great to see co-research so fully embedded throughout the project. And I know you've produced lots of fantastic resources, so really encourage people to follow that up and look at the website. We'll move on now to Gabrielle Meagher's presentation, so taking us away from England and into the Australian context. Gabrielle's presentation is on navigating the home care market, how older people are expected to access home care in Australia, and I think it's really interesting to see some of the parallels as well as some of the differences when we look at these two cases alongside each other. So Gabrielle, over to you.
Thanks very much, Catherine. Hello, everybody. My name's Gabrielle, and in my research, I'm interested in the impact of marketisation on care for people who need it and on care workers. And in this presentation, my aim is to explore how the market for home care in Australia is presented to older people and how they appear to be expected to navigate it. Care for older people is primarily the responsibility of the national government in Australia, and there's very little involvement in funding, provision or regulation at the lower levels of government. And adult social care isn't really a concept we have here. People with disabilities who are under 65 receive care in a different system, and older people are in the system that's called aged care. Now, aged care has been increasingly marketised in recent years in Australia, very explicitly with the goal of empowering older people by introducing competition and choice. And some of the recent developments in the design and the implementation of the market in home care are my focus. Next slide, please. So these are the main aged care programs in Australia, and I just want to give a bit of an overview of that. So the grey bars show the coverage of people 65 and over of that particular program, and the pink bars show the share of total spending on all age programs that go to that particular program. So we can see here that Just under 6% of older people are receiving permanent residential care. Just under 4% receive a home care package, and about 20% get some form of assistance from the Commonwealth Home Support Program. But you'll see the distribution of resources, which is the pink bars, is quite different. Residential care takes the lion's share. That would be maybe common in many places, more than 50% of funding. And focusing in on home care, there are the two programs. The packages receive more funding than the home support program, which latter serves a lot more people. So there's only 1/5 as many people receiving a package, although the total funds going to that program are much greater. So looking in a little bit more detail at the two home care programs, both of them require assessment under the National Needs Assessment Program to get access to a public subsidy. But interestingly, people who are assessed for a home care package, the assessment process is the same as the one for residential care, whereas the home support program has a sort of a lighter assessment process. The home support program is conceptualised as entry-level care, and people can get all kinds of supports to help them stay at home. A lot of people get services, as you can see, but on average the level of support is about 3 hours a month. And it's a block-funded program, and its capacity, how many people get served and how much they get, and any rationing that happens is determined by the capacity of the providers that get funding. Can they squeeze another person in within the envelope of services that they've got? Providers tend to be non-profit, and historically they've been fairly locally based. This is generally considered to be a very successful program that could do with more funds. The home care package program, as the funding suggests, is conceptualised as more intensive support, even up to substituting for residential care at the higher levels. It's organised into 4 levels. Level 1 to meet basic care needs. That's funded at $9,000, which is about £5,000 a year, which equates to about 2 hours a week of support. And at the other end, level 4 is designed to meet high needs, and it's funded at $52,000 or about £29,000 a year. And that equates to around 10 to 13 hours of support a week. Now, capacity in this program is determined by annual policy decisions to release packages or places in this program, in the same way as residential care places are released, to meet policy goals at controlling the cost and the structure of the aged care system. The main thing to note here is that the number of home care packages that are released every year is not related in any way in policy to the number of people who are assessed in a separate process as eligible or as eligible for a package and in need of one. So the effect is a significant undersupply. At any one time in recent years, there have been twice as many people assessed as eligible for a package as being able to get one. And there's a waiting list of 100,000 people every year, and you have to wait a year to get a package. So this program is the one I want to look at in more detail. In 2017, as part of the ongoing marketisation of care, funds for home care packages have been allocated to an individual person. So you have your needs assessment, you're allocated a level 3 package, you wait a year, finally the funds are released, and you can take that package to a provider. And you can allocate those funds according to your needs as you see them fit within a prescribed set of things that you're allowed to use the funds for. You can choose to have your package managed by a provider or manage it yourself, but managing it yourself is not a cash for care program. A provider still has to hold the funds and do all the financial acquittal. What you're able to do is to choose the care workers and the services that you want to work with. There's no data on how many people self-manage, and my understanding is it's a minority. Now, as Mo was saying, it's in line with what Mo was saying, choice of provider is expected to fit a couple of purposes, and the government's explicit about this: improve the fit between the consumer, or the customer, and the service, and to drive competition that will increase quality. And, if you're not happy, you're supposed to be able to move to another provider. And so this puts a lot of responsibility on consumers to evaluate quality and to move if they're not satisfied. So for a market to achieve these goals, people need to be able to find a provider with a good fit and be able to change provider if their needs are not met. Next slide, please. So we do have a consolidated, supposed one-stop shop for information about aged care services on a government-run website called My Aged Care. This is on the front page of that website. You can also call a phone number to get help. And this is an overview of the 4 steps that you use to access help as presented on the landing page. And I sort of want to take you through a hypothetical journey to give you a sense of how some of the steps work, not in lived experience of older people, but in the process as it's presented by this website. So I've talked a little bit about different types of care and the assessment process already. So let's move on to finding a provider. The first hurdle that older people face in getting access is getting access to the market, as I said, because you've got to wait for a year to get a package. But once you've been allocated, you need to find a provider. Let's just look at how that works. Next slide, please. First, we're going to search for a package provider, typing in our postcode and selecting a home care package under care type. If you could make that slide bigger, please. You can see in the bottom left-hand corner, care type. That's where you put home care package, and under services required, you put level 3 package. You can make other selections under language, specializations, and so on, but most providers seem to provide most specializations, and the number of search results doesn't really change at all when you enter things into those parts of the search engine. Next slide, please. So I searched for a home care package level 3 in the postcode of a town in the middle of New South Wales, which is a state of Australia, and the town has a population of about 10,000 people. You'll see that I was offered 36 results, ordered by relevance. It's completely unclear what relevance means. The top 2 listings have offices located in Croydon in Sydney, 300 kilometres away, or in Queensland, about 1,000 kilometres away. That's quite a bit further than the distance from London to Edinburgh, or about as far as from Paris to Berlin. There are some providers that have local offices, but you have to click on the individual listings to find that information. The same search for a level 3 package in an inner city suburb in Australia's largest city gives more than 100 providers, also distributed very widely in the city and across the country, because this is a national system. The number of providers has increased greatly since the market, this additional step of allocating the package to the person rather than providers tendering for a number of packages. For the 3 years up to middle of 2016, there were about 500 providers. By the middle of 2019, there were 930 providers, a growth of nearly 90%. And of the new providers, nearly 80% were for profit. So the share of for-profit providers has increased from 13 to 36% across the 4 years of this new system. Now you'll see beside each provider there's a compare button, and you can select up to 3 providers to compare. When you compare, you get a page like this. Next slide, please. You'll see here that the top line is quality. This is the only quality information given, and it's defined as current or past notices of non-compliance or sanctions. The page continues, giving hourly prices for various commonly used services, management fees, contact information, and so on, and providers are responsible for providing this information and keeping it up to date. Now, being able to compare and the requirement for providers to publish the information, price information on the site, were features that were added 2 years after the program shifted to an individualised funding model, with the aim of improving the quality and comparability of information about providers. Before that, providers uploaded brochures to the site that you had to download and do a manual comparison. However, as I aim to show you, there are still some problems with this system that suggest poor and inaccessible information are not the only things making the market challenging for older people to navigate. Next slide, please. Now, I put together an example package just so that I could compare the prices of different providers for the same package. So we don't need to look into this in detail. It's just so that you get a sense of the how I've gone about it. So some personal care, some domestic assistance, some in-home respite, and an hour of nursing, totalling to 15 hours and 10 visits a fortnight. There are a range of other sorts of services that are available that you can use the package funding for, but I've just gone with these ones. At the time I did this analysis, the government subsidy for a level 3 package was $33,500, which is about $1,300 a fortnight, or £720 a fortnight. The services that I've chosen here are mostly the less expensive ones when you buy them on an hourly rate. Next slide, please. Just as background, this table shows the mean price charged by a sample of about a dozen providers for the services in the sample package: personal care, nursing, cleaning, and also the management fees. So the main thing to focus on is the bottom line, which shows the ranges. You can see they're quite wide. And there's also very wide variation in the management fees, from nothing to $400. So some providers charge twice the rate of others for specialised services like nursing, or charge a much more expensive rate on a Sunday to have personal care, for example. Next slide, please. So what I've done here is to cost the package as using the price information given by a fairly random selection of 12 different providers for exactly the same bundle of services. The items that are captured by the red bracket are the services that are covered by the government subsidy, and the value of the package for a fortnight is the red line. The sub-value of the subsidy for a fortnight services is the red line that's across the top of the chart. So as you can see, the total package cost in relation to the amount covered by the subsidy varied from around $80 for the cheapest package to around 80% for the cheapest package, to 115% of the value of the subsidy for the most expensive package. And as you can see, more than half the providers here would consume the whole subsidy or more for that package of services. Non-profit providers tend to be more expensive than the for-profits because they all charge a care management fee, and most also charge a package management fee. The cost for the specified bundle of services only, shown in grey, varies from around $780 to more than $1,100, with the most expensive being a for-profit provider that doesn't charge any management fees. So it can advertise itself as saying, we have no management fees. and the cheapest is a non-profit that charges a fairly modest management fee. Travel charges are mentioned by only a handful of the providers. That's the hatched area at the top of some of the slides. It may not mean that the provider doesn't charge travel prices, it just means that they haven't specified them. Now, the minimum daily fee, basic daily fee, is something that the government says everybody's supposed to pay, and it's around $144 a fortnight. But it's not clear that providers actually do charge this fee. The three that do include it in their charges are non-profits, and it's non-profits that are most likely not to charge it. One of the for-profit with the red arrow, pointing to it on the bottom there, mentions the fee on its website as something that everybody pays, but it doesn't include that in its account of its fees on the My Aged Care page. So it's all pretty confusing. What older people are meant to make of this information, even if they could download it all, put it into a spreadsheet, make a comparison, I really don't know. There's no information that might help a person understand why prices for the same service are different. Even if you were to choose a package based on price, if your needs were to change, say you wanted to have you wanted to have more care on a Sunday or an extra hour or some allied health, physiotherapy or something like that, since providers have got such different ways of costing services on different days and costing different types of services, might mean that if you were choosing on price and your needs changed, a different provider would be would be cheaper. So, you get the picture. People are expected then to contact the providers, and My Aged Care gives guidance on what they're meant to look for, suggests questions that they ask. But the advice on quality refers back to compliance with standards, which is a low threshold because of pretty low quality oversight, which I won't go into here. And you saw that information was just a tick box at the top of the page when you made a comparison. Now, the idea of these consumer-directed packages is that a person decides what services they need within the allowed list of care and support. It's hard to get an idea of how much you can actually get from a package. You can go to providers' websites for more information, but this can be quite misleading. Next slide, please. To give a couple of quick examples. So this is from the website of a for-profit provider that doesn't charge any management fee. They say the amount of the subsidy will cover 23 hours per fortnight. But that's only if the person chooses personal care and domestic assistance on weekdays, which are priced at this provider's cheapest hourly rate. Next slide, please. Another for-profit provider suggests you can get 9 hours a week for a level 3 package. But again, the subsidy buys 18 hours per fortnight at the cheapest of all their hourly rates, plus the provider's $159 a week management fee. So this is quite typical. Non-profit providers tend not to put this kind of guidance on their web pages. They say, call us and talk with a care manager and we can develop a plan that best meets your needs within the envelope of the package funds. Next slide, please. It's quite difficult for older people to work out how to use their package and how to work out how to choose a provider. I just want to say something briefly about the next stage of the process of navigating the market, and that's captured by the phrase managing your services in the overview that we looked at before. Once a person makes a decision about a provider and the services they'd like to receive with their package, they're expected to work out a care plan and enter an agreement with the provider which specifies exactly which services they'll receive, who'll deliver them and when. So the very idea of the market and the consumer choice and exit as the driver of competition puts a lot of responsibility for quality oversight onto older people receiving care in their families. If you're not satisfied in the first instance, you're expected to take this up with your provider The next step would be the National Aged Care Quality and Safety Commission, but their oversight is very weakly developed, and there's been a lot of problems with that system. Next slide, please. You might say that very few older people would attempt to go about the process in the way that I have done it. I couldn't disagree with that, but I guess what I was trying to explore with this analysis is to show that the market is challenging to navigate in the following ways. There are many, many providers to choose from. That's good from a theoretical perspective, but it incurs very high costs in terms of time and effort needed to compare them. Many don't have a local presence because it's a national market, and it's hard to see how they could work in non-metropolitan locations because the distances are pretty vast. There's very wide variation in prices for common services, an unknown relationship between price and quality. The product of a home care package is, by definition, multidimensional, and providers are likely to have different strengths and weaknesses along various dimensions, and that's, in a sense, just what this chart is trying to give an idea about. Even if you have good information about them all, you'd have to have very clearly ordered priorities to choose among providers given their complex arrays of strengths and weaknesses. Quality information is in fact poor or difficult or costly to access if it can be accessed at all. And as I mentioned earlier, being able to change provider is the main promised means of enabling people to find a better fit if they're not satisfied. But this will require at least, in addition to the sorts of problems that Mo talked about continuity of care and all other difficulties, there's a costly new search, and it might incur monetary costs because providers are permitted to charge exit fees and require notice periods. So overall, we've got a picture of something that's very difficult for older people to navigate, even if there's a sense that they've got tens of thousands of dollars, tens of thousands of pounds to spend on meeting their needs. It leaves a lot of effort to them in the ideal model. Thank you. Thanks very much.
Thanks very much, Gabrielle. I think it's really interesting to see, I think, underneath some of the kind of market ideas, how these things actually work, and to sort of follow the path of a consumer through it, and see the kinds of choices that are available and just the sheer complexity of that. So that was fascinating. We'll move on now to Emily Byrne, who's going to be the discussant, reflecting on the two papers that we've heard. Thanks, Emily.
All right, thank you. So first of all, just want to say thank you to both of our speakers for two very interesting and insightful papers. So I suppose it's my role to kind of summarise what we've heard and also to try and pick out some of those key themes that we could sort of discuss. So certainly from Mo's paper, we heard just about sort of the difficulty of accessing information and sort of the issues around the accessibility of information, and also just how hard it can be for self-funders to navigate around sort of different sources of information. So I suppose something that kind of stood out is this idea that theoretically self-funders, it's this idea that they have a greater level of choice, if they do have access to those funds. But actually, when you look into how the system's played out, there is a sort of a lack of choice and also control. I think something that very much stood out to me within the paper was just the idea that often these decisions are being made sort of when people are in sort of a state of distress, or they're facing a particular emergency, and just the complexity of individual situations, how that can affect sort of how they navigate and interact with the system as well. And also just that this idea that people just don't know where to go to get funding, where to go get information, shall I say. There's sort of limited awareness of social care funding in and of itself. And then in Gabrielle's paper, it's really interesting just to hear things from an Australian perspective. And like Catherine said, sort of being able to sort of map that route sort of that the consumer takes in order to access information. And And again, I think it just came out there just how difficult it is and complex to navigate the information that's provided. I mean, it certainly felt like it's information sort of structured there in ways that maybe, you know, sort of it's there for a professional, someone who, you know, it's their bread and butter. They're sort of dealing with this sort of thing sort of every day. But actually, if you're someone who's looking to access services, you know, just how difficult it is to make head or tail of some of that information that's presented. I think sort of weaved throughout that paper is just the idea of, you know, the difficulty of accessing information, how that's really kind of at odds with the aim of increasing empowerment and also choice for people accessing services. So I suppose I wondered whether there was kind of any sort of work that's been done on sort of just how people do navigate this information. I suppose, you know, I was wondering whether there's sort of quite a place and a role for people sort of relying on word of mouth, sort of hearing about providers and sort of accessing providers through recommendations of others. But then, you know, obviously what happens to those people who maybe can't rely on those networks, who maybe don't have access to those sort of networks, or what happens to people when they're trying to navigate this information. And it also struck me sort of the high proportion of people who are assessed as being eligible to receive care and support, but actually, you know, they just don't, they're unable to access that support, and just, you know, that high level of need that's not being met, and what implications that has, particularly, you know, obviously on people's lives, but also on the wider health and social care system within Australia. So I think that there are some wider themes that we can pick out from both papers. So theoretically, kind of this idea of choice and control, it, you know, should have implications for quality of care. So again, in theory, the idea is if someone has the ability to choose a provider, then it can increase competition between providers and drive up standards, quality, innovation potentially as a result. However, both papers kind of demonstrates and questions this idea of whether there is choice if the information that's provided is quite sort of inadequate for someone to actually use to make a choice. So I suppose across both settings, both across sort of England and Australia, I wondered whether there are sort of areas of kind of shared learning about the provision of information. So what are the sort of particular gaps that we can identify across both systems, and how these potentially can be addressed. And then just as a further point, I suppose often people accessing services are described as active consumers, but then, you know, we've heard a fair amount within both papers that there are barriers, you know, to someone exercising both exit and also voice. And so I was just wondering if it's even appropriate for us to use the word market if there are barriers in this way. So can we actually say that there is a market in operation? And I also wondered whether the role of geography and location might be a further point for discussion. So, I mean, often we talk about sort of the experience of accessing services within a rural location in England, but I'm aware sort of within Australia that's, you know, on a whole completely different level. And I wondered whether there's some scope for us to explore the implications of sort of geography and location on accessing choice of provider as well. And I suppose there's maybe a point around sort of the level of administration to some extent as well. So in Gabrielle's paper, it sort of was referenced that often sort of the information is kind of provided on a national platform. But within England, it's the role of the local authority to shape the market and to ensure the provision of information, advice and advocacy. And so I just wondered if that's something else we might want to explore. Sort of, does that those different levels of administration, does that have sort of any effects on people's experiences of accessing choice? And just as a final point, certainly in England, social care is often being described as sort of being in crisis. And I was just wondering, kind of, if we wanted to think about some of the implications of our use of that term crisis. So both kind of at level, the discourse is around sort of this idea of social care being in crisis, but also whether there's kind of any implications of that for people who are potential users of social care, and also sort of people's general sort of wider understanding of social care more generally as well. So I suppose those are my comments, my points, and I'll probably leave it there. But again, just to thank both of our presenters for two very interesting papers.
Thanks, Emily. Yeah, as you say, there's lots of kind of interesting things to get into, real sort of knotty issues around the care market and its capacity to develop equity and inclusion as sort of key principles that we might be committed to around care. We'll move now then into the broader kind of discussion phase of the session. So bringing Mo and Gabrielle back in. I wondered, just thinking about some of the kind of hooks that we might use for this session, if we start with choice, or perhaps that broader concept of choice and control. I think both of you in your papers have problematized choice as it currently works, and Emily has also highlighted some of the problems with choice. We know, though, that the concept of kind of more choice-based approaches to care and support for older people isn't just necessarily something that's been sort of dreamed up by private providers and kind of marketeers. It's something that older people's organisations, disability campaigners campaigned for because of the limits of kind of what went before, I suppose. So I suppose I'm wondering, how far does what you've said suggest we should give up on choice within care systems, or is there a way to kind of make it work in a more meaningful way for people so that it is part of a commitment to equity and inclusion? Gabrielle, I can see you nodding. Do you want to go first and then Mo?
Yeah, I'll just say something briefly. Look, I totally agree with you that research about older people's perspectives does say that they value autonomy and being able to have choice in their daily lives. I totally agree with that. I guess how I see this market that I was talking about working is that it's asking people to make decisions and choices about things that they probably, they're not maybe the choices that help them achieve the autonomy and control over their daily lives that they're looking for. So I guess that's where I would be saying the market doesn't work very well. There's too many providers. You just offered too many providers, and how you're supposed to make sense of that and choose between them, I really couldn't say. And then because of the necessity to manage private providers is the whole contracting thing. You've got to make a contract that specifies everything, and then you've got to renegotiate the contract if your needs change and so on, so that this kind of being a contract maker and a customer in a market with a large number of choices just doesn't strike me as the optimal way to give older people, the sort of control and choice in their daily lives that they're looking for.
Yeah, thanks, Gabrielle. Mo, what are your thoughts on that?
Yeah, I think the issue is it was very difficult for people to make choices in the absence of choice, but also if there were choices, theoretically choices to be made, often people didn't feel that they knew what kind of criteria they were applying to make a reasoned choice, which lies very closely to what Gabrielle has just been saying. So for example, when we spoke to older people who had, over the course of the interview period, and indeed unpaid carers who'd been involved in purchasing a care home, for example, theoretically there was a choice, of care home, but they were sort of left driving around, aimlessly wandering around care homes without really any kind of criteria for making that choice. So I think that's a difficult issue. And certainly in terms of the interviews with older people, in terms of the choices that they would like to make, they would like to be able to get a service where they had some degree of continuity, reliability in the care that they received, that their relationships could build. There was a relational aspect because they knew the people who were supporting them and providing care, and that they felt confident that the people had the skill to do that. So, the sort of, do I have a choice between 8 care agencies is a kind of was almost for the older people that we interviewed a kind of spurious idea, because how do I choose if none of them can offer reliability, none of them can really offer continuity, and I'm at the get-go having to make very significant compromises about when I'd ideally like someone to come.
Yeah, indeed, and that's come out certainly in research that Emily and I have done around care markets. That point about kind of continuity and quality of service is so important, but choice doesn't seem to get us to that in its current way of operating. Another issue I thought might make a kind of interesting thing to reflect on is around the kind of the point Emily raised about the kind of the market. Is it really a market? And one thing that we found in the research that we did was that the market wasn't really working for anyone. So it wasn't working for providers. Certainly in our English-based research, the providers are being, paid at the kind of bare minimum of what they could do to function, which means they can't pay their staff well, which means staff don't stay, which means you don't get the continuity, you don't get the quality. That's clearly not working for the commissioners of care, and certainly not for the people receiving it. So I suppose, and that to me has just come out very, really strongly again from your presentations. So I wonder, perhaps Mo and then Gabrielle, whether, I guess it's your sense of kind of who is this market working for? Why are we here?
Yeah, I would agree. I don't think it does work for anybody. That we interviewed a whole range of stakeholders who were labouring under really serious burdens. The interesting thing that I found, and I know that this might resonate with your work, Catherine, and I wanted to ask Gabrielle about this as well. Certainly in Lincolnshire, we're seeing a growth of so-called unregulated carers. So they're independent carers, they're working micro businesses or sort of micro enterprises, and they're providing care for very small groups of people, often within quite a tightly framed community or location. I mean, they've been in the care sector, but they've left, usually because they're aggrieved. And paradoxically, although there was a lot of concern about regulation, safety, training, and so on, paradoxically, they were in a better position to provide choice, flexibility to older people. And they found as workers that they were in a more satisfying job role. They earned more, they passed some of their cost benefit to individual older people, so they paid less. They did less work because they were earning more, and they were working within a smaller geographical location. Now, I don't want to idealise that. There were some real challenges associated with that. But I was interested to see that emerging in the absence of a market that was working in any sense or in a way that helped people, that this had sort of floated into the area as quite an important means of provision, certainly in rural Lincolnshire. And I wondered if that was happening, Gabriella, in your context, that individual practitioners were sort of emerging away from the sort of mainstream provision.
I don't know I haven't done any research, any field research on the structure of the supply side of the market. So I've just used this kind of more published data to get a sense of that. I think I'll just say one other thing quickly. Something that I didn't talk about in my talk is about the emergence of platform providers, so gig economy platforms that are finding ways to connect themselves to things like quite tightly regulated programs like this package program. They're managing to connect to that for people who want to be self-managing their own package. But I actually would pass to Catherine on this. Is something that Catherine has done a lot of work about, and I think she would be better placed to speak about that as an issue of micro businesses as a kind of a emergent solution.
Yeah, no, I agree. It's a really interesting area, and I suppose this is the sort of paradox of markets, is that in a number of projects that we've done, the people who were kind of had their own, perhaps their direct payment, so that they were kind of managing their own money directly, who were able to kind of make choices in a kind of local market of provision, were the people who generally were getting the best support. Much better than the people on the whole who had packages put in place for them by the local authority. And there's obviously issues there about the capacity of certain people to manage a market, and that there are equality and inclusion issues there, I think, about that not being evenly distributed. But generally, we did find that people who were using these micro providers that did seem to be a kind of almost like a win-win, and I think, as Mo says, we don't want to kind of be too naive about it, but I do think on the whole it created better quality care and better working conditions for the people providing it. They're often kind of very local, so that particularly in rural areas, that made them kind of viable and sustainable, because people can't have these big contracts that cover enormous geographical patches. The point Emily made about kind of geography being relevant here. So we have seen some great, I think, examples around that. The unregulated nature of these makes people very nervous. There's obvious I guess concerns there, but I think given the very poor quality of lots of regulated care, I do think we have to be careful kind of what we're comparing with, and we're not comparing, the regulation is clearly not delivering on quality in the sector. So I think I wouldn't want to kind of, I'm not too troubled by the unregulated nature of this. There are some issues about kind of level playing field, and I know in some areas that's been a real concern. So there's been some hostility from the larger care companies towards the micro providers, because we're feeling like we've got to jump through so many hoops, and we've got to do all this regulation, and we've got to pay all these different things that we have to do for compliance. Those guys over there, no one's paying any attention to them. So that's what, in areas that we're trying to have a kind of mixed portfolio of provision, we did find that this created some real tensions between providers, and that got in the way of being able to, I guess, providers kind of work across and kind of network with each other and develop the kind of partnerships that some local authorities were trying to create. That there were clear kind of, it's difficult having different rules for one provider versus another, and I think that's, providers feel quite troubled by that, and I can understand that to a degree. So yeah, I think there's lots of interesting things going on around that particular space. I wonder if we could perhaps focus a bit more explicitly on the geography point that Emily raised. I know, Mo, in your research you worked in Solihull. I'm not sure whether Lincolnshire was a site, but I know Lincolnshire is a very large and very rural county. So I guess, did you find any difference in kind of urban and rural settings?
Yeah, we did. So there were more independent carers emerging in rural settings, and I think that was an interesting kind of solution to the absence of care providers from more traditional settings. Interestingly, also in Lincolnshire, there were larger numbers of people who were using living care at home, and that seemed to be partly because there was less choice of care home that was near to home. As the distances to travel were much further afield, and if anyone needed any kind of specialist care provision, they would have to travel too far, and if they could afford it, they were staying at home. So they were either having periods of living care to accommodate for kind of intensive respite, or in the event of accidents and injury or unexpected events. And some people were having living care as a permanent, very, very expensive feature of their lives. So I think that was quite interesting. And of course, people were buying lots of additional services around things like transportation to multiple appointments that were away from the villages and the outlying areas that they lived. So they tended to buy more to manage those sorts of appointments if they didn't have family or family nearby. And finally, care agencies and individual carers often negotiated differential rates to accommodate for further distances and wear and tear on cars. So they were negotiating an enhanced rate to take account of rural locations.
Interesting. Gabrielle, given that you're you do urban and rural to the max in Australia, do you have any kind of reflections about that?
Just as I said, I haven't looked very closely at the organisation of the supply side outside my aged care, but people who live in rural and remote areas are considered a special needs group, and their access to services it does get some special policy attention. But I guess what I would say is that I think the idea of the national system with the national portal, with the providers claiming to be able to, that in a town of 10,000 people, where there might be only 200 or 300 people who would be eligible for services, there would be 30 providers more than 30 providers who'd say they would be available there. There's something not quite right there, and that some more genuine regional organisation of the system where providers needed to have a local presence might make the choice more real for people and more just cognitively manageable.
And I suppose, I know, Emily, in the work that we did, you looked at two very urban sites and things. I guess although you would expect there to be better provision in urban settings, sometimes things like land prices means you can't set up a care home in a London borough or whatever. Emily, I don't know if you have any kind of reflections from that sort of urban experience.
Yes, yeah. I suppose it's just like you said, sort of just the number of other factors that seem to come into play and affecting sort of providers' ability to invest and to assess. So yeah, so we're working in one particular area, sort of London, and just the cost of land to try and set up a new care home was just so prohibitive that, and obviously then that led to a sort of a lack of supply in the area. So yeah, it's very, very complex.
This issue of living care, that's interesting that you raised that, Mo. That's not been something that's been a big part of the English care provision in recent times. Gabrielle, is that would you say that's a significant feature in your understanding of how people get support in Australia?
No. I mean, if you compare the coverage of things like residential care and the packages program in Australia to the coverage of those sorts of services in southern European countries, it's much, much greater here. So we've actually got quite a relatively high coverage of residential care, which is, I think, the main thing that live-in care substitutes for. So to the best of my knowledge, it's not a big thing.
Not to overstate it, but I was just struck by, out of the sample of people in Lincolnshire, the number of people who were having living care, and they were all serviced by care labour from overseas. So that was another sort of observation. So I'd quite like to do some more work on that, really. But at the moment, I mean, it seems to me to be prohibitively expensive for most people. So these did tend to be people who, as self-funders, were very much at the higher end of sort of income and assets, but they were spending eye-watering amounts of money on living care.
And I think you're right. It is growing. That's my sense from other conversations, that it's not been a big feature. And I think it would be a really interesting topic to do some more work on. As you say, it has really interesting reflections in terms of the who does the living care, and that often has been the kind of migrant workforce, and in other countries' experience of living care. And I think it's interesting to sort of see that in the UK as well. I think there's also interesting issues about the grey economy and kind of who gets paid for what and when does it become kind of care, and some of those issues I think become a bit more resonant around the live-in care.
Yeah, absolutely. And interestingly, again, in rural Lincolnshire, I interviewed 2 cleaners. So they provided cleaning services and domestic services. But as their clients aged and developed care needs, they increasingly were providing more care services and giving examples of, getting people into baths, getting them out of beds where they'd lost continence or they'd been very ill in the night, so quite significant levels of care which they were doing completely sort of under the wire because they've got this long relationship with these people, and they said, well, what am I supposed to do? If they're torn up and they're in need and they know me and they trust me, and oh, will you cut my toenails and I'll pay you extra for it, kind of thing. So that's sort of care emerging from a relationship that was established for a different reason. And again, I don't want to overstate it in the context of the sample, but I think it's worth, as you've just said, Catherine, I think it's an interesting question to look at.
I think that's quite a big issue in Europe, because in some countries the sort of funding instruments kind of promote domestic services and care as a kind of joint industry. So that can be something that's promoted by policy, that sort of blurring and overlap. But here, I guess it's an absence of policy. People aren't engaged in any government program.
Yeah, and I think there's interesting kind of normative questions there about, is that do we want to sort of celebrate that as kind of people building on existing kind of networks and making things work for them pragmatically, or do we want to raise safeguarding concerns because getting somebody into a bath if they've got mobility issues is potentially problematic. So fascinating. So yes, definitely an area that would merit more attention. So I guess I've raised. Go on, Mo.
I just wanted to, I was very struck by a similarity that Gabrielle raised about the wide variations in cost in care services, and that's something that we found. And on that basis, people found it so difficult to judge value for money when something costs £18 an hour and something costs £12 an hour. How do you determine what the extra £6 gives you when it appears to offer precisely the same? And I just wanted to reflect that back to Gabrielle, because she highlighted very significant diversities in care cost.
And that's, the providers that I was, talking about there, most of them would be just providing subsidised services. They wouldn't be also having a private, a self-funder operation, although they do offer that service. But what struck me about it was that it's all sort of inside a government-sanctioned system, the information about the wildly divergent prices and so on. There's no price controls. There are price controls in the parallel system that is funded for people with disabilities, and that is considered to be a source of terrible problems as well, because the government wants to keep the lid on the cost of the system, and so they fix kind of a efficient price for various kinds of supports, and providers find that very difficult to deliver good quality care. So, and as we saw, probably the good quality non-profit providers, they charge more, probably having better working conditions, better care management that takes more time, and so they have to charge you for it, etc., etc. So then you have the sifting of the people who've got more money can go possibly to the better providers, because they can top up the public funds with their own contributions. So, or you luck into a better one.
Yeah, and I think that another issue of price fixing for the working age disability has been a real problem. So yeah, there's sort of, I guess again, there's sort of, well, do we want variable price or do we want fixed price? They've clearly both come with significant issues. And I think you raised the point in your presentation, Gabrielle, that price and quality do not match. It's not, although in some cases it might be that you pay more and you get a not-for-profit who pays their staff really well, and you're kind of paying for that, and people might be comfortable with that, but that's not. There's no guarantees that that's what your extra money is going on.
No.
Great. Do we have any other questions, comments that anyone would like to bring in at this point?
I would like to go back to the issue that Emily raised about information. And obviously, Mo, you talked about this quite a lot as well. And just to just make some very brief comments about the role of information, and also to connect to Emily's point about where are people using word of mouth and things like that, and who's got access to good inside information about providers. One of the things that's happened in Australia is that, and I guess it happens everywhere, is that a whole set of, because the market's difficult to navigate, a whole lot of intermediaries emerge, and they can be private consultants or government-funded advocacy programs or care navigator programs and so on, which also addresses Emily's question about, is this really a market? So because consumers, it's not just about interactions between those on the supply and those on the demand sides. They need to be intermediated. I think the idea that people just need better information is a little bit just like saying people just need more choice, or people want choice, so let's give them choice of provider. People don't have information, so let's just give them information, like a website where they can get the price information and et cetera, the mission statement of the company or whatever it might be. I think we have to really think about what sort of information people are lacking and what kinds of supports they might need to navigate the system, because just from an economistic perspective, the idea is that, if consumers have better information, then they can make better choices. I think it's only part of the story is to just provide better information.
That's often the response. Yeah, we'll just get more information on the website, or we'll get more information pushed out via this hub or whatever, but it still doesn't necessarily equate to the kinds of information needs that people have. And I think information is often seen as equal, and it's a much, much more complex process than that. So one of the things that we were saying is that information needs to be sort of tailored to where an individual person is at in terms of their particular requirements at that time, and those information needs will change. So information needs are dynamic, and they don't stand still, but information is often provided at a single point of time, as if, well, we've done that, end of story. It doesn't have that kind of dynamic sensitivity. It's a very big issue, so I can only wholeheartedly agree with you.
Yeah, I'm really struck when I did a focus group with these are South Asian women who are carers for a child with a disability, and everyone in the session had a smartphone in front of them, but nobody was using their smartphone to go on the council website. Even the council had put information up in relevant community languages. That wasn't that. It's not just about making sure that the information is there and that people even have the sort of technology in theory to use it. That's just not how people get information, and so obviously we just need to be much more we need to kind of use the channels that are actually kind of meaningful for people, and often for a lot of people that will be word of mouth and other kind of community groups. So yeah, I think cracking information is so important, but we can't make kind of simplistic assumptions that kind of, well, everyone's got a smartphone, so let's just bung everything on the internet and we'll all be fine. And clearly everybody does not have a smartphone at all anyway, or in rural Lincolnshire, and I'm sure parts of Australia, there's many parts you can't use the internet anyway, or haven't got good broadband, and all sorts of access and equity issues around that too.
Yeah. The word of mouth was certainly very important. We had lots of stories about, I got my carer from the mobility shop round the corner who happened to be speaking to, or the lady up the road said such and such a body is a good place to go, that kind of thing. And we did slightly wonder, although we couldn't really demonstrate this, but one of the things that the co-researchers raised was that the retirement migrants, because we have a lot of retirement migrants coming into the county, were less well placed to pick up on that local information because they hadn't had time to develop the kind of resource and social capital that they might need to be able to access those resources that, to the sort of casual observer or the stranger are quite hidden. So I think that was quite an interesting point, and again, one that I'd like to think some more about.
Any final comments anybody would like to make?
I really appreciated Gabrielle's forensic gaze on this aged care system, which I'd sort of read about in principle, but it was so interesting to see that very forensic gaze on how that system's been structured. And also I really appreciated that. Thank you so much. Is there work going on currently to sort of add on to that in terms of working with older people who are accessing those services and working with stakeholders in terms of their experience of that we can perhaps look at, or
I will. I'm not doing that work, but I will. If you send me an email, I'll find some work and I'll send it to you. It's interesting because a lot of that sort of research that can be commissioned by the government is commissioned from a particular older people's representative organisation that is really, really sort of pro-market. And so they tend to, they say, okay, well, if people, we need to run these, we'll run these trials to help people navigate the market. All we need to do is put more information in and so on so that people can use the market better. But I'm sure there'll be some independent research, and I'll look that out for you with pleasure and send it to you. I'd like to say thank you to you too, and also for your considerate discipline in giving a presentation of the correct length, which I didn't seem to be able to manage. So, because you gave a very coherent and comprehensive talk in the right amount of time, which was fascinating.
Well, I didn't know.
And I took a photo of your quadrants of needs assessment, and it's fascinating to see the to just in a sense have the scales removed from your eyes. That just because people, as you say, self-funders are not all really rich people who should be left. They can just buy whatever they like out there in the marketplace. It's a much more complex picture, and that made me reflect a lot about Australia as well.
Well, thanks very much.
And I know, Gabrielle, in Australia, you've just had a recent very damning Royal Commission, I believe, on older people, which has really sort of shone a very problematic spotlight on the quality of older people's care. In the UK, we continue to lack any kind of plan even for a sustainable funding model, because I think the lack of money in the system for us is not, that won't solve everything, but that is one of the reasons why things are in such a bad state. And I think Emily used that word crisis, and I think that's something we could probably both systems could relate to, in terms of a lack of any kind of sustainable system that delivers quality care, and where there's a real ability to deliver equality and inclusion around care. So
yes. Thank you. Yes, that's right.
Okay.
Yeah. There's just such a big debate about who should pay. And as income inequality gets greater, the idea of a universal system where everybody who has needs should have those needs met just slips further and further away. And that makes it difficult to have a good system for people who don't have money, or people who are in the middle, like this whole self-funders problem. So I think this fear of putting proper resources into the system we have it here, even though Australia's not in such difficulty as the UK.
Yeah. I mean, I think there's the who pays is such a big issue, and then there's a kind of making sure you're not paying into a leaky bucket, which is, I guess, is partly the self-funder issue, is that you're just paying for something which is just not delivering. And I'm sure that, well, certainly part of the sustainable care program and the broader kind of commitment of the team is to move towards something which is more sustainable here in the UK. So thanks everybody for the contributions today. I think that's been a fascinating discussion, part of the series which is looking on care markets, yes, really appreciate all of you bringing those insights today. So we'll finish there. Thanks very much.
Thank you all.
Thank you.
Thanks. Bye-bye.